Okay, awesome. Wow, we're already up to 236 participants. That's actually insane. So I think we can just get started since we're already, a little over. Mark, thanks so much for joining us today. I've been following from afar through Hospitalogy and, the Mavs, of course. But just would, love to kick things off with you. I would just to get started, as an MFFL, I'd be
Yeah,
remiss
I can't
to
even go
mention.
there. I can't even go there.
I know,
Yeah,
I
I
know,
had nothing to do with it, so I can't even talk about it.
Yeah, no, you can no comment me. It's fine, but I just had to say something.
There you
So
go.
it hurts, but no,
Trust
moving
me.
on to healthcare now. I'd love for you to just to talk about cost plus drugs in 2024. What have you guys been up to? You notched some partnerships. How many prescriptions are you up to? I saw you launched the manufacturing facility in January. Give me the kind of the laydown of what's going on with you guys.
Yeah, I mean it's a really simple business. We buy drugs and sell drugs, and we make drugs and we sell drugs, and we try to be as transparent as we can about our pricing. We started shipping January 19th of 2022 with 111 drugs. We're up to about 2,500. For those of you who haven't used the site, when you go to costplusdrugs.com, you put the name of the medication in. If we carry it, it pops up. It shows you our cost. It shows you our markup of 15%. If you get it mail order, we have $5 for a pharmacy review and $5 for shipping. We also have an affiliate network of 16,000 pharmacies now. If you decide to go through the teamcubancard.com, and I didn't name it, then it's the same markup, but we pay $12 to the pharmacist because we want independent pharmacies to survive. And then there's no shipping or anything like that. So it's a $2 net cost more. And that's it on that side. We have Cost Plus Marketplace, which is run by Alan Bowe. And effectively, that's where you saw our announcements with Penn Medical, CHS, and others. And effectively, we're a virtual wholesaler where we just have a 10% markup on most things. And you get to buy it without all the crazy markups that are introduced. It's the same principle on both sides. Why are we in this business? Why is the opportunity here? Because it's one of the most opaque marketplaces and industries on the planet. And that makes absolutely no sense. And when you get regulatory capture, when you get scale capture that's dominated by just a few players like the medication businesses, it opens the door wide open for new players who aren't so greedy. And that's us. And then on the third side, we spent 3 years maybe building a robotics driven manufacturing plant in Dallas, where we make right now sterile injectables. And we also can get special permissions for things that are on short supply and all that kind of stuff, and do deals. But we just started manufacturing in March and have been shipping since. We don't have any one particular focus, but we'll do everything from sterile water to pediatric oncology drugs. And so those are our three lines of businesses, and we keep on growing. Our biggest challenge is just keeping up with it.
Yeah, it's really interesting because I remember you talking about and you guys launching or trying to launch the manufacturing plant kind of earlier on, kind of ran into some hiccups, and now it's kind of cool to see that come to fruition. So it's essentially kind of like vertical integration with like the supply side, right? So how to
Yeah, in essence, but we really don't even try to do it that way. If we tried to really understand the economics of medications and generics and brands. And on the generic side, why are generics in short supply? Well, they're in short supply because there's not a lot of margin for people to make the investments in manufacturing. But then you get to the point where with robotics, we can turn the line in 4 hours. And our biggest limitation in getting something out the door is the 2 week waiting period for everything to, get approved and all that kind of stuff. And so, we're able to just turn things quickly and at a low cost of manufacturing. So you take that starting with sterile injectables, just because we wanted to be able to cover the pediatric market. And then we'll be adding new things in the future where we'll be able to do oral solids, pills, and crank those things out as well.
Yeah, no, that makes a lot of sense. I saw you guys kind of with the CHS partnership, maybe focusing on like EpiPens and those sorts of things. So
Yeah, whatever. Yeah,
that's awesome.
it's all injectables, right?
Yeah.
And the CHS was injectables and cost plus marketplace. So, you're just trying to simplify all the distortions, starting with medications, but across healthcare.
Yeah. No, that's fantastic.
And let me just say this: medications, pharmacy is the easiest business I've ever been involved with to disrupt. And that seems kind of crazy to people. But when you think about it, most of the innovations that people try to introduce are really financial engineering at some level. How do I save 2% here or 3% here? And if you apply that to a big number, then that's worth me investing in and getting a return on. They don't really, they're dealing with all the symptoms and rather than the problems. And we just tried to look at the underpinning of the problem. I mean, pharmacy is so simple. I mean, somebody makes it, they sell it to a wholesaler, the pharmacy buys it, a doctor prescribes it. If you have insurance, it looks it up to see what the elements of the plan are, and then the pharmacist in that last 5 feet delivers it. It's easy. But then you've got the bigger PBMs that come in and complicate it because they know they can extract in an industry this size. 1% is a whole lot of money.
Right. Yeah. When you're talking, big revenue dollars, hundreds of billions, that 1% moves the needle significantly. And guys, by the way, for audience Q&A at the end, we do have a Slido. I think that's in the chat. So feel free to drop your questions there. You can also upvote those if there are certain questions that have already been asked that you want to know. But Mark, kind of, we brought up disruption, brought up innovation. Obviously,
wait, I just got blurry. Hold on, it's because I'm moving. I got one of these items.
Yeah, no worries.
Come on. Either that or I'm blurry.
Camera's kind of coming in and out of focus.
Yeah, it's a new camera. Of course.
Yeah, no worries. Can give you a sec if you want to figure it out, or
let me just try to figure it out real quick. Share screen, profile, statistics. Not giving me anything. Hold on, let me just turn it off for a sec.
Yeah, no worries.
Oh, you stopped video for everybody, so you got to turn me back on.
Oh, JC, can you put the video back on, please? Sorry, folks, technical difficulties. We'll get
That's
back
all
on
my fault.
I'm sure it'll pop back on here soon.
And actually, you don't need to see my pretty face. I know it's exciting.
That's true.
To see.
Why don't we just keep talking?
Yeah,
while
just keep on going like
the
this.
Video. Yeah. So back to kind of my train of thought as far as just PBM disruption. We're kind of seeing the unbundling of PBMs to a certain extent, which is kind of a counteracting force to VUCA vertical integration. So it's very interesting to see those kind of dynamics play out. So for something like the Blue Shield of California deal, for instance, where does that sit today?
It's just, it didn't turn out kind of the way it was directed initially, but we're talking to them again. They added us to their network. It's just it's a work in progress that's had, little things from our end. I can't speak to their end. You'd have to ask them about how happy they are with it. But the bigger issue is you've got the big three PBMs and effectively the big six with the next three with smaller marketplaces. And then you've got the pass-through PBMs, of which we partner with 25 or 26 of them. And what's the difference? The first element that's different is who owns the claim data. If unless you've got 1 million lives or more, or maybe 500,000 lives or more, you don't control your own data, which is absolutely insane when you think about it, because you could cover 50,000 lives and you'll want to see wellness trends and issues, and you have to go to your PBM and ask them for that information, and they're going to say no. And then if you get really, really mad, then they'll charge you for it. And then put aside wellness issues. If you're trying to understand a cost associated with any given claim, they're not going to give you the net cost associated with that claim. Now they're saying they're going to give it to you at some point in the future, maybe in 2028. I'll believe it when I see it. And they're calling that transparency. But if you can't own your own claims data, you can't really be effective in managing HR. But wait, there's more. Not only does the sponsor, or in this case, the employer or state or whatever it may be, not control all their data, the manufacturer doesn't get all their data as well. Think about this. So let's say Lilly or Novo, and they want to figure out, is it true that if you take GLP-1s, there are people that have hearing issues or people that have eyesight issues? You would think you want all, non-patient identified data in aggregate to be available to you. Nope. That's just insane. It's almost like Fight Club. The number one rule of a PBM contract is you can't talk about the PBM contract. And so people don't know what is going on from the manufacturer side or from the employer, the ESI side, employer-sponsored insurance. And so you don't get claims data. You don't control your own formulary. I talked to one of the biggest banks in the world, and we have a product called Usimry, which is Humira Biosim, and we charge $594 a month. And I was like, I bet you it's cheaper than what you're paying, even with all the games that the big three are playing with their own biosimilar. And she says, no, there's just no way. We're sure, we were promised we had the best price. And she checked, and ours was better. And but then she comes back to me and she says, but I was told it only covers, Usimry only works 20% of the time. I'm like, it's a biosimilar, right? If it's
Right.
the same strength and it's the same volume, it works. And so the PBMs just throw out all this nonsense. They don't give you data. They don't let you control your own formulary. There's pre-auth, they have utilization management. And I tried to explain to corporate CEOs in particular that the more rebate you get, let me rephrase that. I asked them, who pays for your rebates? And they say, well, it's the manufacturer. No, even if all the rebates are being passed through, it's your sickest employees that are paying for those rebates because they're the ones that have the highest utilization. So the more they use, the more they pay. The higher the list price is, the higher their co-insurance is, right? The sicker they are, the more utilization, the more rebates that come back. And even if that comes to you, that means your sickest employees and your oldest employers are paying for all those rebates. Do you really want that to happen? Do you want to wake up one morning and find out one of your employees is dead because they couldn't afford it because you had this high rebate and you offered a high deductible plan that one of your employees couldn't afford because your rebates were higher? Whereas if everything was a pass through and you knew what your actual net cost was, you could put together plans, and then it gets worse, right? Think about, and then do you know about all these local independent pharmacies that are closing? And they're, yeah, I've read something about it. And I say to them, you realize it's your fault. They're like, what? How is that my fault? I'm like, you, Mr. C or Ms. CEO, signed the contract that approved the PBM reimbursing that local pharmacy less than their cost for that GLP-1, for that Eliquis, for that whatever that brand is. That's on you because you wanted more rebates.
Right.
They just don't understand. It's not a CEO's core competency to understand their health plans or their pharmacy plans. And my job out there with Cost Plus is to go out there and explain that, it's hard to know the exact number of lives covered by employers. It's anywhere from 100 to 150 million, but that's a lot. And if we can educate enough CEOs to realize that the decisions they make on both the healthcare and pharmacy side for their health plans have enormous consequences in the wellness of the lives they cover, but also in their own economics, then they realize that they should change. Because the beautiful thing, and why I say this is so easy to disrupt, when I talk to a CEO, I'm not in there saying, like, I've worked with technology for a long time. And there's times you say, well, when you invest in this AI, it won't pay off immediately, but in 2 to 3 years, you will see all the benefits. It's not like that at all. It's you're going to pay less. You're going to have healthier employers. You're going to be better for your community. You're going to have, older and sicker employers that are in better position to be able to afford all their medications and their health care. Why would you not do this? And then they go to their consultants, and that's when it gets all fucked up.
Right. But, I would love to unpack that a little more because I've talked to folks. I have a good buddy who's an actuary. I've talked to other folks kind of like on the employer side. And one, so you have like kind of like the lawsuits going on, kind of fiduciary kind of responsibility
Yeah,
and
the
so
ERISA
forth.
lawsuits. Yeah.
But on the other hand, you have like, CEOs who are buddy buddy with CVS. They have those like long-standing relationships. And also, CVS is saying, hey, we have this, vertically integrated, all bundled product, and we can give you our network access and give you our PBM
And
and
that's
all.
fine, right? I got no
Yeah.
problem with that, but the numbers are the numbers, and your health of your employees is the health of your employees. And
Right.
so obviously they've been going back to the big three and saying all these things that we've told them, and CVS is having to respond. And so it's all the big three, not just CVS. All the big
Right.
three are
Right.
having to respond. And now they're coming up with, talking about transparency and cost plus pricing. All this little 3-year-old company has completely changed what they're telling employers about their programs. But what they don't do is publish their price list.
Yeah.
And that's
That's
critical, because the most impactful thing that we have done isn't just our pricing, but it's the fact that we publish the price list. So now everybody, so the people in HR hear about us and they say, okay, let me do a price comparison. Well, all I know is whack the basically the list price of this drug, and when I compare it to cost plus, okay, this imatinib was $2,000, and I don't have any indication that I'm paying less, and it's $21 at cost plus.
right.
Or because of the plan we've set up via CVS, my coinsurance is $170 because my employer chose a high list price version to get of a drug to get more of a rebate, and I can get it, for less than my coinsurance or my deductible at cost plus. And so when employers are coming back to HR and saying this, that they're saying that to the consultants and they're saying it to the CEOs, and they're going back to the big three, and the big three have had to respond. But if you read the quarterly earnings conference calls or listen to them, they all say they'll make up that revenue somewhere. None of them are saying we're screwed. It's just
Right.
is what it is. We're going to
Yeah.
make less money on these medications. They all have ideas, and I can tell you what they're going to do. They're just going to keep on increasing charges to, manufacturers first and employers second, because then they can say my net price is lower, but the overall portfolio cost, if you will, the macro cost to the employer isn't going lower, and the charges to the manufacturers are going up as well. So their net revenue is going down.
And to your point, kind of on, the earnings calls and moving money around, those sorts of things, like we're already seeing signs of that as far as like moving profit pools over to like GPOs and like management
Yeah,
fees on the
that
GPO.
gamesmanship is insane, but we've kind of
Yeah.
shut that down. So
Is
I've
that
seen
right?
one of the questions. Yeah, I've seen one of the questions is, when are you going to get more brands? We do have brands. I think we have like 75. It's a pittance compared to where it should be.
Yeah.
But the reason why we don't have as many brands, and this is in the process of changing, is because when we go to manufacturers and we say, well, why don't you just, work out a rebate program with us, or just give us a net price? You can charge us more on a net revenue basis than you get from CVS or Big Three or whoever. We're fine with that, and we'll just mark it up 15%. And they say, Mark, I can't say what I'm going to say, so I'm not going to say it. But you can imagine that the big players in the market, because we really need our positioning in their formularies, might not take kindly. And if we lose that positioning on the formularies, then that's billions of dollars. Okay, I can't argue with that. And so what ends up happening as a result, you see the other pass-through PBMs, or all the pass-through PBMs, working with PhD and others, Ascent, to have them be their rebate GPO. And they just get, they get a fraction of the rebates that the others do. And so the pass-through PBMs have to use things like Usimry and other biosims, one coming out with Stelara, several coming out with Stelara, and put together portfolio packages that they sell to the employers, and then bundling them all together. What they don't get on the brands, they make up for on the biosims. Now, the question becomes, can we do the same thing? And that's what we're in the process of doing.
Mm.
We've created our own rebate GPO, and we're in negotiations, not just with, a PhD type player, but also with the manufacturers themselves. So we'll see how they respond. Um, we think that we're going to be able to do some de facto formulary plays because that's what they respond to. Early on, I said it's net price or nothing, and for brands. And so it was like, okay, end of life brands, brands that have generics, that have taken their place, and others, we got those. But now we're saying, okay, we'll play the rebate game, and we'll just pass those rebates on completely, and we'll just take our net cost to market up 15%. So we're in the process of making that happen. Hopefully over the next few months, you'll see us start to add more and more and more brands. But the goal here is, so the bigger picture on a macro basis is, what's the tipping point? What's the tipping point at which the big PBMs don't have the leverage to control what the manufacturers do of brands because they need that formulary placement? Is it 50 million lives? Is it 25 million lives? Is it 100 million lives? We think there's about 22 to 25 million lives this year going through the pass-through PBMs. And the big manufacturers can't ignore that. So we're not getting everything, but the conversations are happening. And now with Robinson Patman being discussed, which is a issue about legal pricing mechanisms that started in the grocery industry. There's all these issues that are coming to light that I think that door for brands is going to open for us.
Yeah, that makes a lot of sense. I think one of the biggest questions people had obviously was around the brand name drugs. And so you've got a lot of biosimilars coming on the market. I think several notable ones over the next couple of years. You mentioned Humira already.
And then the other thing is we can manufacture those injectable biosimilars.
Yeah.
We can make those. It's just, we had to go through that cycle that all startups go through is, how are we going to do? Okay, we're doing okay. Oh shit, right? We got to keep up with growth. Now we can start thinking 2, 3, 4 years ahead. And so now we can start putting in applications or partnering with people to say, whatever things are coming off a patent in 2028, 2029, 2030, and 2031, let's, get involved in applying and going through the process. And maybe even that process will simplify here over the next few years so that we can turn them more quickly. But we have the capacity and we have the facility to be able to make our own biosimilars.
Yeah, that's fantastic. And is your manufacturing plant, is that a compounding pharmacy or how's it?
Yeah, I mean, we are officially a compounding pharmacy.
Okay. So you could do GLP-1s if you wanted to.
Yeah, we could, but we chose not to. We actually bought some tirzepatide just to do some tests. But we're not going to fight, what's legal and what's not legal like some of the others are. And because, it doesn't cost us a lot to make. I think all in, fully burdened with overhead manufacturing and everything, it's $20.
Wow. Yeah, that's pretty crazy. But I imagine you would, run into some maybe short-term profits,
it's
but
just not worth
long-term.
it. It's just not worth it. Yeah, it's not worth it.
Yeah.
We want to be, good. We want to follow all the rules because trust me, with me, with my name on it, they're going to come hard at me if we even skirt even a little bit of a rule.
Yeah, and to your point on kind of following the rules and like doing the right thing. You've talked a lot about transparency in healthcare and like being a public benefit corporation. Can you like talk about how that plays into kind of your governance, your investment decisions, and like do you think that should be?
I just want to fuck up healthcare. It's really simple. The whole thing is a mess. There's nobody who thinks about the financial side of healthcare and says, this is great. Let's keep on doing it. And, you can try to, consider single payers / universal healthcare. And I'm not opposed. I think healthcare should be a right. The question is, how do you get there? And without transparency in an opaque industry, having the government negotiate without all the information they need. Like if you look at the PBM report that the FTC did, they couldn't even get all the data. If you look at some of the research that has been done comparing cost plus pricing to what Medicare pays, our pricing is less.
Right.
And so what does that tell you? It tells you that even if someone tried to transition to a single payer today, it's going to be too expensive. And that's just on the pharmacy side. I can go on for days. On the healthcare side, it's even worse. I mean, the spread pricing and the things that go on there. I mean, I'll do one thing because this is my favorite. So if you think about deductibles, co-pays, co-insurance on the healthcare side, not the pharmacy side, but it applies there too. Who takes the credit risk, the credit default risk of the deductibles, which are defined by the patient and the plan they choose, and the BUCA, using them as the examples, and the plans they create?
Yeah, the provider.
The providers
yeah.
and the plan, the companies and whoever, even the government, right? When they approve Medicare Advantage plans, when they the state, when they do things for employees, Medicaid, even to not quite as much, but they all set the deductibles. And who takes on the credit risk of a deductible, co-insurance, or copay? The providers and the pharmacy.
Right.
The most insane shit in the history of insane shit, right? Because it means, by definition, people's interests are not aligned, not only with each other, but with patients. And because, we know how expensive all this is, particularly to individuals. So you may choose a high deductible plan out of necessity, not because you're 22 years old or 27 years old, but because you got no choice. And then when it comes time to pay, maybe you have a plan that you bought direct from a BUCA, and you go to the hospital, something bad has happened, and you have a $6,000 deductible. Well, the contract between the provider, the hospital in this case, and the BUCA says they have to provide the care, which means now all of a sudden, if that's a $5,000 deductible and this person has $1,000, there's $4,000 to be collected. Who's the bad guy in all this? The provider. They're the ones that have all that debt. They take that on. And when you talk to hospitals about this, it's just insanity, because they have to collect from patients who a lot of times can't pay. It could be millions of dollars for a hospital. And then when they have a contract and the deductible is paid, for the portion that's to be paid by the BUCA in this case, they have to fight them over it. And they're not going to just pay. And it's not just about pre-auth, right? It's about, okay, we know we contracted and we owe you $10,000 for this hip replacement. We're not going to pay you $10,000. We're going to pay you $8,000. So now the hospital has to have a zillion lawyers, a zillion administrators, because for every new plan that BUCA creates with all those crazy deductibles, because they're trying to get more corporate accounts and get more plans for people to accept, for every one of those plans, there's more administrative costs.
Yeah.
So,
and to your point, sorry, go ahead. Keep going.
So now the hospitals have all this administrative costs for lawyers and trying to, collect bills and all the real estate, all the benefits associated with those people. And so, when you read about the cost of healthcare, and it's 20 to 30% administrative costs, and everybody says if we just go to single payer, that all goes away because Medicare is only 3% in administrative costs. That's all true, but that's dealing with the symptoms and not the problem.
Right. Yeah, and to your point, you can go to a hospital and you have care done, and you can say, at time of bill, hey, like what's the cash pay rate, and it's 30% cheaper. Yeah,
yeah, that's what we do with my company, right? For the lives that I cover, we're doing all direct contracts, and so when you sit down with the provider and you say to them, look, no pre-auth. Okay, that's a good thing. We're going to trust the doctor. We're going to trust and verify, to paraphrase Reagan, right? But we're going to trust the doctor. We're going to put a deposit down. We're going to pay you cash for everything. So the minute the service is provided, whether you're primary care or surgery, the money is already there. Now unless it hits our reinsurance cap, which for us is $75K, then it's got to go through the reinsurer. Okay. So we're going to cover that. Because it's cash, you don't have to worry about collecting from us, and because the other thing that payers do, that BUCAs do, is they'll do pre-auths and deny initially, not because they think it's going to stay denied, because they'll go through all the process and take the 2 to 3 weeks and suck up all the doctor's time, knowing they're going to approve it, but they get the time value of the money in the interim. And in aggregate, that's a big number.
That interest carry.
Yeah. So we're saying, look, we're going to pay you cash. You're not going to have all this administrative overhead. We're going to have very simple plans, and we're going to cover the deductible too, because we're telling all of the lives we covered that everything for in-network might have a copay, might have, depending on what it is. But for now, to get started, we're covering everything outside of copay. And they're like, great. And we're like, okay, but we want a discount, not just your published cash price. We want it even lower. And we're getting 100% of Medicare for some things, 120% for Medicare for a bunch of things. For the stuff that's high-end specialty, we've agreed to 250%, but in all these cases, we're saying that they're non-exclusive. So if we can find great care, or there may be doctors that our lives are already working with, and we'll negotiate directly with them. But across the board, we're saving anywhere from 20 to 40% a month so far. And it's the same concept with pharmacy. If it comes through Cost Plus or it goes through one of our local pharmacies who do have the brands, we're getting, our price or better pricing, and we're doing no copay for our employees. And as long as we're on top of the wellness side and, communicate with the doctors, we haven't had any abuse, and so far it's been great. And and the whole big point of this is the whole process on the healthcare side, as it's been on the pharmacy side, is all about simplification, not complication.
Yeah.
All the people trying to reduce the cost of healthcare are effectively trying to insert themselves to try to improve a process that's part of the complication process, which is nice, but you're taking something that's already too hard, making it less hard, saving people some money, but you're not dealing with the real issue. And so we're trying to take everything back to 1955, because that was the year from Back to the Future. And just saying, you go to the doctor renders services, they tell you how much, and if they can't, if the patient can't afford it, they did a payment plan. Well, we're just saying, whether it's a hospital or a doctor, the same thing. We're just saying, as a company, we'll take responsibility for that payment plan, and we'll pay upfront, or the reinsurance will pay for it. Totally simple. But here's the kicker. All the contracts we do for direct contracting, we're going to publish them this year. So that just like when we published our price list and companies got to see they were getting ripped off, they're going to be able to compare our direct contracting contracts. Now, a lot of the stuff is complicated. If you are inpatient for 7 days in this hospital and then we double the price, and then we subtract 30%. A lot of it's complicated, but it's a start. And as we start that process, and people get smarter about negotiating, and companies get smarter about their plan and how they can use their cash, because for a big company that's not cash constrained and can get great rates on reinsurance, if you self-insure, if you're not direct contracting, you're an idiot. Yeah. And I know there's a lot of consultants that say otherwise, but and they bring up the point, well, you can't direct contract everywhere. Well, you can work with a BUCA to get a wraparound network that's just not your primary, right? Yeah. And try to do everything on a cash pay. And like I do with the lives I cover, here's the credit card. To your point, Blake, ask for the cash price before you tell them you have insurance. Give us a call, presuming it's not an emergency, and we'll figure it out. And then God help us that, the BUCAs are using these, what's called multi-plan, right? Where they spread price on out of network. What a horrific ripoff that is. Like, okay, your kid breaks his arm in a soccer tournament, out of town. They go in, they get the arm fixed, they're going to charge you $4,000 because that's the median price in the market where the kid broke his arm, right? But they only paid out $1,000. Come on, man. And then there's facility fees and the games that are played there, because the providers, they're not getting paid as much as they think, and so they're doing all the P's, making all these acquisitions because it's an arbitrage just to get the facility fee for new patients coming in. Come on, man. I mean, all this shit is easy to fix. The missing link is just educating CEOs on how badly they're getting screwed, and how the wellness of their lives covers suffered because of all this gamesmanship. And I understand, because I looked at, before we got started with Cost Plus Drugs, I was like, I just trusted my guy, right? My consultant that did all this. Right. And the conversation was, well, everybody else is getting a 7% increase, but I convinced them to only give you a 3 to 4% increase. Oh, great. Thank you. Yeah. And then when we started Cost Plus and I compared, the price we were paying for generics to what the Cost Plus price, I was like, oh, and you said you were my friend? I mean, I just felt dumb as shit, you know? And that education process and going through and expanding direct contracting, and we're not the only ones doing, having efforts with direct contracting. There's a lot of folks out there that are doing the same thing. And so we're all starting to work together. So this is going to happen. And back to single payer. If everything is transparent, look at it from my lives, right? The lives I cover, Mark Cuban companies, the lives I cover, we have single payer because I cover pretty much everything that's in network and everything else. And there's just
Yeah.
a minimal out of pocket.
Mm-hmm.
Now imagine if every states were able to do the same thing, or counties or cities were able to do the same thing. If all the numbers were in place and you knew and you could, do some planning and projecting, you can have a decent idea, particularly with reinsurance, what your out of pocket is going to be for your health care and your pharmacy. And if you have a budget that can cover that, now you can be single payer for your city, county, or state. That's the progression. That's effectively what happened in Canada. It was, I forget which province, because whatever. But there was
Doesn't matter.
one in like, yeah, there was one in the 40s, I think, that started doing this, and then it spread to another province and another, and then the whole country picked it up, I think, in 1965, 17 years later. And so if we start that process, then people have a choice. Employers can do it, if it's single payer and there's a defined amount, and an employee doesn't want to be underneath the employer's plan, even if it's all covered, they want to do it themselves. Great, here's all the costs. You know exactly what you need to do, and the conversation can be had about separating what the employers are doing with healthcare versus what individuals need. But if there's no transparency, if there's no taking it down, if there's no simplification, single payer, universal healthcare as a right can only happen if healthcare is simplified. And I'm not talking about using AI for diagnosis. I'm not talking about patient and care management and using, those are all good fundamental things.
Right.
But on the economic side, all the complications there need to be completely simplified. And if they are, then we can go in the process of doing all the things where healthcare truly is a right.
Yeah, I love those thoughts. It's so funny to me because I'll read and see other things, and intellectually it's such a simple exercise, like cut out middlemen, improve policies, etc. I'm curious for your thoughts, like with that kind of administrative complexity, kind of like the fraud, waste, and abuse, but also like that 30% number within like local markets. All those administrators, all those like middle managers, call them, like those are like jobs, right? And so there is like political pressure. And so I'm curious for your thoughts around like if disruption happens and that 30%, which is, however much of
With
GDP,
the amount
like,
of money we could save, we could pay them as a country to go to the gym and work out
yeah,
as
no,
a
for
job.
sure.
Because if you get,
That's a good point.
if it's 4.9 trillion off the top at the top, right? The total amount, and there's 30% off the top, that's 3.5 trillion. We've saved 1.5 trillion. Now, if you start then at the provider level, start saying, okay, instead of us paying instead of us paying 250% of Medicare for most things, or higher, right? 80% of what we do is now at Medicare because it's cash pay, the equivalent of cash pay at scale. Because let me just tell you this. So the next question this all leads to is hospital costs.
Right.
Every hospital will tell you we lose 8% or more. We get killed on Medicare or Medicaid. Bullshit, right? Because that same hospital, when you ask them how they do their accounting and what it costs them, they have no idea. And that same, I talked to, not, I don't say all of them, I've talked to some that have, but I just talked to one the other day. I don't know, right? Well, how do you burden your procedures in terms of costs with overhead? It's hit and miss. We just try to make it all up on all this other stuff. And so literally, because they don't know if they make money or not on Medicare and Medicaid, they jack up the price and everything else. So I did a study about 5 years ago where I paid this company, research company, and I said, look, let's start with a basic premise. A hospital in Toronto and a hospital in Manhattan, do they have the same costs? Doctors are more expensive. Nurses are more expensive in Canada. The cost of Band-Aids and all those things, all the supplies, more expensive in Canada. Real estate, more expensive in Canada. What's less expensive? Well, they do cover malpractice insurance in Canada. So that's one out of pocket that's not there. And the big difference is capital expenditures. In Canada, hospitals just don't go nuts to expand to just get as big as they can and brand as much as they can. So there's a lot of marketing expenses that don't exist, and there's a lot. And the big thing is capex, because if you keep on spending, for any Monty Python fans out there, if you always need the machine that goes bing, right, that you want to show off, or because you think you need to have all the market share for one category and you wanted to be the brand for that, you don't need to spend all that capex. And if you don't spend all that capex, or if you spend it wisely so that there's already need and you can cover the cost, now all of a sudden you can make money at Medicare rates. And so that there's bigger questions associated with that, like who pays for the investment for not MRIs, but the latest and greatest robotics, this and that. But those are conversations you can have when you're direct contracting, you can have with employers, you can have with the BUCAs, and you can make decisions. But what happens now is there's an arms race. Like Dallas is such a growing market. Almost all the systems make money, but they're in an arms race to keep on spending to get more of that money, because the CEOs get promoted. The more revenue they generate, the more market share they have, the more money they make. And I don't mean to just dump on hospital and network CEOs, but it's true. You want to go to the next greatest, biggest and greatest, and then on the rural side where, I just read this book, The Hospital, and the one takeaway that I really took from it, and it was interesting, but the one takeaway was small hospitals pay more for basic things than medium to larger side hospital. Like the Smith and Nephew replacement hip that I have, the small hospital might pay 2 or 3 times more than the big hospital. And so hopefully at some point, Cost Plus Marketplace can get into those things and just, create some equilibrium for their costs, because we don't pay attention to those things when we think about, what it takes to run a hospital successfully and profitably at a price point that aligns with patients, because that's what it comes down to. And Canada has been able to do that by limiting care. So I'm not saying it's going to be easy. The NHK, the UK has been able to do the same thing by NHS by limiting care, and limiting access. So I'm not saying it's easy to figure those things out, but you can figure them out. But the way it is right now with no transparency, like if it was up to me, I wouldn't be worried about pricing transparency from providers. I'd be worried about cost transparency from providers. Just like we show the cost of what we pay on Cost Plus drugs for Tadalafil, one of our highest. I think we have a huge market share of Tadalafil. Like I tell my friends, it's cheaper to buy 90 Tadalafil from us than it is to buy a bag of M&Ms. But I digress. But if we forced hospitals to open up their general ledgers, then oh my God, think about the change, because then what the margins are. And they might say, well, it's competitive, we can't disclose all this stuff. We're talking about healthcare here. We're not talking about practice. We're talking about healthcare, where we're trying to align interests of the patients. And literally, if we want to change the game, if somebody's out there buying hospitals and they start publishing their costs rather of everything, so people get to see and can start analyzing it, and you get some wisdom from the crowd, healthcare can change.
Yeah, and to your point on the hospital side, I used to work as a valuation consultant, so I would see their books to value their departments, and all I would see was kind of their contribution margin by service line, and then all of the overhead we essentially had to make up or like allocate in certain ways. And so it's just like such a mess. And maybe that's changed since,
No, it
probably
hasn't
not,
changed.
but
No, it's just
yeah,
gamesmanship, right? And
yeah,
when you see, like, if they came into Shark Tank and I'm like, what's your overhead to do these procedures? I don't know, but we
no
know we
idea.
have this much margin, so
Yeah,
we've got to make it up somewhere else.
right.
Well, can you cut your expenditures so your cash flow, because in your business, you want people healthy, right? And then, and it's not all their fault because, like I said, if they're accepting all the credit default risk and there's, depending on the size of the hospital, $1 million, $5 million, $20 million in bad debt was never that high, but some huge number in bad debt. Okay, we start by realigning pricing, direct contracting, and then open the kimono, open the books, and the
Yeah.
whole industry changed like that.
Do you think because essentially like more or less what you're trying to do is kind of like open source contracting and provide more like pricing transparency and those sorts of things. Like, do you think pricing like slowly kind of homogenizes over time with kind of the introduction of that? Is that kind of your end goal?
Yes or no? I mean, look, part of this equation also is how much do doctors get paid. Like, it is
Right.
stunning to me how little doctors get paid.
Yeah. On the professional
Stunning,
side. Right.
stunning to me that there can be some complicated heart surgery and they might make $1,000. Like, literally, you don't even want to know the shit I've spent $1,000 on, right?
Right.
It just makes no sense.
Big screen
And so,
TV, plumbing,
yeah, right.
Yeah.
Plumbing, exactly right. The garden, gotta make sure my wife didn't hear that. But you get the point. And
Right.
so all of these misalignments of interest, we need to get there. And it starts with transparency and simplification. So you're not going to see a monetization of price, but you'll see the people with the greatest skill get rewarded the most.
I
And
gotcha.
yes, you will get paid more for having the new machine that goes ping. And so where there's new technology that can do something better, that's more efficient, has better outcomes, and you can say to, all the employers, all the even the payers that you deal with, that the payers are still in the mix. We'll get to that in a second. But you can say to them, look, here's the option. It's better wellness. It's going to cost like GLP-1, right? There's probably a machine equivalent of GLP-1s to get certain things done that hospitals will have to invest in. And as long as it's transparent and as long as everybody knows what's at stake and what it should, and then you can have a discussion on what it should cost, then the hospitals can make more money. The doctors can make a lot more money because that transparency lets everybody kind of create an equilibrium of an alignment of incentives for
Yeah.
all the participants. And then you
Yeah.
come to the question of, okay, for the employer sponsored insurance, by definition, they're self-insuring. What's the role of a BUCA? Why do you need them? Why do you need the big three PBMs if they're not transparent and you don't want their rebates?
Right.
I ask this all the time when I talk to groups. I'm like, what's the one thing a PBM does that is unique and differentiated and you can't live without?
What's that?
No one's ever raised their hand.
I
And
guess.
on the BUCAs,
Yeah.
I can see putting together a network and some software and care management. That's great, but you can disintermediate that, right? You can segregate it
Sure.
into different functions and buy those individually so you can go get it from the best of class.
Yeah.
This whole industry is like the old, when I started selling local area networks and writing software, it was like no one got fired for hiring IBM.
Right.
Now it's
Yeah.
just like the consultants and brokers just automatically send you to a BUCA or a big three PBM or together, obviously, and they just collect their money and say, well, you got to go to them. They're the ones going to write you the biggest rebate checks.
Mhm.
And we're in this interim period right now where the BUCAs and the big PBMs, they know all these things are changing and transparency is happening. And so what they're doing with their biggest, and this is expected and it's actually smart, what they're doing with their biggest employers is they truly are passing through all the rebates. If you've got 1 million lives or more, you're getting all the rebates. You're getting whatever you want. Why? Because if the PBM loses that volume, that million lives, lose a couple of those, million live whales, they're shit out of luck.
Yeah. Seems like there's a lot of, as has been the case for several years, the rebate game is just very opaque in general between employers and PBMs, et
It's
cetera.
coming to an end for the biggest accounts, but it's still, fraught with, I don't want to say fraud, but greed for everybody else.
Yeah, that makes sense. Mark, would love to pivot over just kind of to some audience Q&A. There's
Sure.
some questions in the queue. I think we've maybe talked about this a little bit, but are there any plans to move from prescription drugs only also into the health insurance space? So
No, I don't think there's a reason for health insurance to exist. Reinsurance, yes. Health insurance, no. For if we get to single payer. So no, we're not going to get into the health insurance space. But we're going to try to make it so for all the self-insured employers, there's no reason for them to work with insurance companies, if that makes sense. And then you look at the ACA and what happens there. And if you get the feds with to start understanding that they're enabling all these issues, to start putting together programs, then if it's transparent, they may be able to compress the cost down enough that they become the guarantor of any debt that's required from a patient, a person, right? And someone who has an ACA plan. Because, and then Medicare Advantage, they keep, a fundamental thing for me is that the feds should put together a network that if you're gonna be part of a Medicare Advantage plan, if you're gonna be part of original Medicare, you are part of the federal network, and that's available to everybody. Now you might set higher prices over Medicare, but you make it advantage because part of the gamesmanship is constraining networks. That's what Medicare Advantage does to make more money, right? And then they do, denials, and we've seen the numbers with the, 17% denial rates and all those games that they play. Mm-hmm. But part of the thing that would disintermediate and disrupt all that is, now pretty much any hospitals, I don't know the exact rule. If you take federal money, you've got to be part of Medicare, right? Mm-hmm. And you've got to accept Medicare. But if you made it so that there is a federal network that every hospital has to be part of, and that any plan that is part of a federal approved plan, whether it's original Medicare, Medicare Advantage, and maybe even for private companies, the ESIs, the game changes like that. And then the only question becomes, how do you call out the hospitals, the providers, on the fact that, to your point, Blake, when you worked with the hospitals, they didn't know what their costs are. Why do we let that? Why is the health of our entire country based on providers who don't know their own fucking costs?
Right. Yeah. Well, insurance side too, right? You have it from top to bottom. There's this okay, I'll take my margin, we'll lock that in, then we'll ask for 8% on the top. So it's kind of like this layered effect, right, of all these input costs, and there's no incentive to kind of drill down into those gross margins, into those allocations, and it's all just kind of like this cesspool of everyone.
Yeah, I mean, you actually get to see it, right? They're not going to open the books to me. I mean, all the different hospitals you dealt with. I mean, that's the problem.
Right.
That is the problem. And it not only is it on the back of CEOs for using consultants that don't really go to the core of the problem and are just trying to make money, it's on CMS as well.
Right.
Why are they approving these plans that put the out of pocket on the providers and pharmacies, and why are they approving plans with constrained networks? And why are they not saying, if you want any money from me, you got to publish your general ledger?
Mm-hmm. Yeah, it just seemed like I think across the board, a theme that would be great for healthcare is just increase transparency, and people don't want to do that. They don't want to open up their books because one, they're scared of what that would do to their business. That's a risk to them, right? It's a
no, if
trade
I owned
secret.
a hospital, right, I'd be angry too because, presumably me and my board have some understanding of sorry, there goes again.
Oh, you're fine.
Presumably some of us have some understanding of what's going on with our own costs, like you said, the contribution margin of different things. But okay, this isn't the Dallas Mavericks, or this isn't cost plus drugs. This is the health and welfare of our entire country.
Right.
And if you wanted to, I'm a capitalist through and through. Every ounce of me. I mean, an Ayn Rand fan, you name it. Howard Rourke was my hero. But at the same time, you can be compassionate in certain industries, right? You don't
Absolutely.
have to, just grab every nickel that you can get when there's this at stake. And so if they're not going to be compassionate, quote unquote, then yes, the Fed should say, we're not going to legislate you more, but you got to open the books. We want transparency. We don't want to create laws that try to, finagle to get you where we're trying to go, because government sucks at getting companies where they're trying to go. We're trying to get cheaper healthcare and pharmaceuticals. So we're going to create the IRA with all these laws of unintended consequences. We're going to make you publish all your procedures so there's complete pricing transparency, even though, on a cash basis, you can be a consumer if it's not an emergency, but for emergencies, yada, yada, yada. No, we're going to just make you publish your costs.
Yeah.
And we're not going to approve any plans that don't require every Medicare hospital to be part of the network, and accept all these things we just discussed.
Yeah, no, that's fantastic. Hey, Mark, we're over by like 3 minutes. Do you have a little more time?
Yeah, for sure. I was late, and I love talking about this stuff.
Okay, sweet. No, I appreciate it.
And if there's anybody out there who thinks I'm an idiot and all this is wrong, speak up, right? This is how I learn, right? You learn by being questioned.
Hey, I'm happy to keep doing follow-ups. I mean, we could do like a 4-hour session if you want. I could talk about this all day too. Okay, so kind of like on the policy side, we've kind of touched on that a little bit recently, like CMS and like cost disclosure and those sorts of things. Are you working with anyone on Capitol Hill, like working with legislators?
Well, it's all changing right now too, right? So,
right.
I've talked to people who are supposed to know the people that know the people who understand what the people think is going to happen. But who knows?
Because there was, PBM discussion, PBM reform, those sorts of things.
There's lots of discussions, but how do you make it happen? And if PBM reform is just about, okay, no more rebates, we'll just make it up somewhere else.
Right.
If PBM reform is about, paying full amount to the pharmacist, okay, they'll just make it up somewhere else. And so that's why the transparency is important. And that's why CMS making better purchasing decisions. It's not about IRA. It's about, I'm happy to negotiate with the government for the generic side of things that we cover. And I'm willing to bet that if they there's laws right now saying that they can't negotiate directly with pharma, right? And if you just change those laws and open it up.
But what does negotiation mean? Is it just like, the net price that's already out there?
No, that's the whole point. If there's transparency everywhere else, you get to see, you'll get to see what our costs are. You'll get to see if we publish contracts, right? And we'll tell you what our net PBM, our net for brands, what our net costs are. And most of the manufacturers publish their net revenue because they want everybody to know. The big manufacturers hate the big PBMs, hate them with a passion. I embarrassed the shit out of them somewhere. I was at some event and I went to the pharmaceutical companies and I said, how many of you, for your own benefits, for your own company with hundreds or thousands of lives covered, work with the big three PBMs? They all raised their hand. And I said, for your best-selling oral solids and your best-selling drugs, even, I said, how many of you get reimbursed? How many of you paid the PBM more for your own employees, for your own drug that you manufacture, than you get back from the PBM? They all raised their hand. It's just insanity, right?
Yeah.
And so when you talk about can the government get a better price, shit, just ask me. I'll negotiate for them. They will get a better price. They can't do any worse, and they complicate things so horrifically, right? Just keep it simple. And when you make decisions for plans for the ACA, for Medicare Advantage, don't don't just approve everything. Set some parameters that offset the things that you know are going to create problems and are misalignments of the interest of patients.
Right. Yeah. No, that makes a ton of sense. And Mark, I think we're pretty much at time now. It's like we're like 5 or 6 minutes over.
You got no other questions for me?
Oh, well, I mean, you want to keep going? We can keep going
Yeah,
if you want.
I'm fine. Yeah, I'm fine. Yeah,
Okay,
I've got a good
sweet.
20 minutes.
All right, great. So we talked about administration policy a little bit. Here's one. It's got several upvotes. Have you interacted with kind of like 340B at all?
Yeah, for sure.
Because obviously hospitals, that's a huge point of contention in the industry this year. How does that factor into?
I like what J&J has proposed, right? Where it's on a rebate basis, even though we hate rebates, because it is abused. I mean,
Yep.
you've looked at hospitals. I've talked to hospitals. They're
Right.
trying to squeeze every penny that they can get. The entire healthcare industry is an arbitrage.
Mm-hmm.
It is not a healthcare arbitrage, it's a financial arbitrage. And
100%.
so every complication that's introduced, including 340B, is an opportunity to arbit. And that plays to the private equity companies who know it even better. So it's not just about, site neutrality. It's also about 340B. So if this hospital, or this, entity buys this entity, now they can run the 340B. That increases their margins and da 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 da. It's a joke. And so there is value to 340B, but again, transparency of the transactions, because when I've talked to pharma, they can't get all the claims. Remember what I talked about, right? You
Mm-hmm.
can't get all the pharmacy claims. And so they don't know that which claims are being double dipped and which claims are being abused. And so what they can do is they can look to see how much they sold into those hospitals and how much money came back and how much relative to 340B, and they don't match up.
Right. Yeah, and to your point, you purchase drugs for one price, you sell them for another. That's the arbitrage. But what would you say as far as like there's a lot of health systems, a lot of hospitals, probably even like safety net, who aren't really probably the problem here, but it encompasses that 340B margin is like quite literally their entire margin, like to help them, reinvest and pay their nurses, et cetera. Like how do you solve for like kind of complex problems
There's
like
nothing.
that?
Look, if that's acceptable, just make it transparent.
Sure. Okay. Yeah. Fair enough.
You could go to a pharma manufacturer and say, "This is where we are," you know,
Just meet in the
and then
middle.
and
Like,
then it
see.
gets worse. And let's just talk about all the cell and gene therapy, all the $1 million drugs.
Yeah.
If it were me, and it's not, if I was CMS, I would go to all those manufacturers and I would say, open up your books. Here's a deal I want to make with you. I'll cover your cost every year for this cell and gene therapy because I know that you price based off the fact that there's a limited population that will need this drug, and there's even a more constrained population that has the economics to pay for the drug. And
Right.
so if there's 1,000 people, you may decide that only 50 people will pay for it because all the bukas are lasering that shit out, right? And nobody is able to pay for it. So if you let me cover your costs in exchange for every Medicare and Medicaid patient that needs this, probably won't be many, but everyone that does, we don't pay anything more. If it's $1 billion that I give you, it's $1 billion. If it's 500 million, 300 million, whatever, that's it. It's like a Netflix subscription, all you can eat. But in exchange, in terms of pricing to everybody else, I want you to do a set markup on that price. And maybe even consider doing a subscription version for employers, a quarter per live per month, and give it to them. And we'll make sure all your out-of-pocket costs are covered by the employer or by Medicare or whatever, so that having family stay there, so that's not overwhelming to the patient. There's ways to deal with those things, but you've got to innovate and you've got to be transparent again, and you've got to be honest because like I helped these twins out that had this genetic disease, where it was $2.4 million. And the insurance company just refused to pay for it. They said, whatever excuse. And the manufacturer wouldn't give them a discount at all because in their mind, it's like this happens every day. There may only be 1,000 potential patients, but 900 of them are coming in asking either for a discount or for free because the insurance company won't pay for it. They said it wasn't part of the plan. And so I stepped in, and the first thing I did was say, okay, go to the hospital and have the hospital ask the manufacturer for a 340B price. And all of a sudden, the 340B price wasn't 2.4 million, it was 1.8 million. Okay, that's a savings. Then, we threatened to embarrass the administration, the Biden administration at the time, and all of a sudden Medicare covered it. And so if you can go through the process and be transparent about what's going on, we can solve these problems. The solution may not be perfect. The solution is going to have, law of unintended consequences and things we didn't think of. But if it's transparent, you'll learn and you'll adapt. And, things will still go wrong, but at least it's on a great path. That's better than now. So to deal with all these things, CMS has got to be able to go out and negotiate. Whatever laws need to be changed, they need to be changed.
Yeah, the irony of kind of like healthcare in general is like you said, it's very simple, but also like the patient and physician relationship is just like such a trusting relationship, and then everything around it is just shrouded in opacity, right?
Yeah, by design.
So,
by design.
Right. Yeah.
That's how can you charge the most? Don't let people know what it costs.
Right. Yeah. And so yeah, okay. So moving on. And maybe we've touched on some of these things, but maybe just kind of like drilling down into it. Like what's the biggest pushback or point of concern like you get from CEOs or like potential employers? Like what advice like would you give them when they're reviewing PBM contracts or whatever?
Real quick, I saw one of the questions from Michelle about it not being easy working at a pharmacy. I'm not suggesting it's easy working at a pharmacy. Pharmacists are being ground down to nothing. And that's one of the reasons for our network, we pay a $12 fill fee because we don't think pharmacies are being rewarded, and we're pushing against you guys being under reimbursed. But generally, not the individual pharmacy business, but the industry itself, knowing that pharmacists, in particularly independent pharmacists, are not being fully reimbursed, that's easy to understand.
Yeah.
And having people understand that and making it part of the contracts we do with pass-through PBMs, that's easy to get them to do. Helping CEOs understand that they're putting you out of business, that's easy to do. I'm certainly not saying the pharmacy business is easy. So I'm sorry. So go ahead, Blake.
No worries. And to that point, like functionally, that's a very similar trend to what you're seeing on the primary care side too, right? Like they're getting pushed down, professional reimbursements getting pushed down. There's higher dollar specialty care downstream, like, profit centers. So it's like, how do you solve for that? And how do you support the PCP? So that's why you're seeing a lot of like direct primary care and like the parallel healthcare system, like as you kind of talk about a lot. So
yeah, I mean, look, direct contracts. I want every doctor and nurse to be paid more, a lot more. And who's pushing down the price? It's the payers, and to a big extent, the providers, because not everybody's aligned. Right. Doctors and patients are aligned. They want the healthcare. They want their patients to be healthy.
Right.
Period. End of story. And the patients don't mind paying a fair amount to the doctors because they want to be healthy and they want great doctors. Like, again, I'm not in charge, but I would make at public med schools, I would make them free with the stipend because it's a great investment. Right. There's 900,000 doctors in this country, and that number is declining at not a big rate, but it's declining. But they all go to specialties where they can get paid because they graduate with all this debt. And it's not about the government paying off the debt after the fact because the med schools jack up the price, which leads to more debt. But if you just make it free, and if and set the pricing. And again, it won't be easy to negotiate that. But what did I look at? There are 90,000 med students. I forget if that's for 1 year in any given year or all in aggregate. But for $6 billion a year, I do remember that number. For $6 billion a year, if the average med student needs $100,000, and I guess I can do the math backwards, but for $6 billion a year, you can make med school free. Now, if we can reduce some of the overhead from 4.9 trillion to 4.8, 94 trillion,
Right.
we can pay for med school.
Yeah, that makes up the difference, and such a great investment for long-term
Yes,
potential.
and
Healthcare.
it's six.
Yeah.
It's not that 6 billion is nothing, but 6 billion is nothing in the big picture.
Yeah, right. Especially like when you think about the budget in general, like you mentioned, whatever that comes out to within even healthcare itself.
We could spend $6 billion on pick something, right? Or $6 billion to get us more doctors that have a more variety of specialties to make us healthier. Where would you rather spend that money?
Right. Yeah. Again, all these things seem like a no-brainer, but it's like in practice.
They are a no-brainer. They are a no-brainer. Now, it's easy to decide. It's easy for me to say, but legislation is messy.
Yeah. Yeah, of course. Okay. Yeah. So back to, I think one of the questions, I think we have some HR folks on the line just because one of my colleagues writes a HR newsletter. So he invited those folks as well. What are kind of like the as you're talking to employers and CEOs, what are the biggest points of pushback or concern, kind of like common talking points when you're kind of in those meetings that, they need to consider or think about?
They all say the same thing. I didn't know. That's it.
They don't know the games that are going on.
It's not their core competency. They got companies to run.
And so functionally, how do you solve for that? Like,
I say, who's your consultant? Let's get the HR person in the room. You should be talking directly to your HR person. There shouldn't be an intermediary. The best solution, I tell them, is to have a healthcare CFO that deals only with healthcare because it's your second largest expense item after payroll.
Yeah.
And so, you should have that person paying attention to all these things. And you get your consultant in here or your broker and you ask them how they get paid. And if you're paying them $200,000 to do this, then you get your money's worth and you ask them why are all these things happening? Mm-hmm. Because they're not doing their job if you're paying them. But really, if you're paying them $200,000, you can hire somebody from that company that works specifically for you, that finds all these things and helps you understand. But even then, it's not their job to look at the big picture. This as an entrepreneur, this is what I do, right? This is who I am. I try to look at complex industries and say, how do I simplify them? Everything that I've done, that's what I do. And so when I look at it, I don't look at these things as, okay, how can I make as much money as I can using technology to improve the pre-authorization process? How can I make it so it's easier to collect debt? No, right? It's like, why are we in this situation? And going back to what do the CEOs see and say and do? It's just banging on them over and over, because the first thing they realize is they can get a better deal from their BUCA/PBM by bringing these points up. And then they start to realize, because I stay on them, that, okay, maybe for this next RFP, we should include cost plus drugs and we should include a direct contracting option. And let's, take that approach. That's what we're seeing now. More and more RFPs going out that include net pricing and transparency and payment to pharmacies, full payment to pharmacies, and all these things. And it's freaking out initially the PBM business because that's where the focus is. But once we start, if I can get my network of direct contracts built enough and we publish those contracts, we'll have the same impact on BUCAs that we've had on PBMs.
Yeah, well, I would love to see that. That would be fantastic.
Me too.
And honestly, like the idea of the healthcare CFO, like just focused on making the benefits decision, like that sounds like one of the highest kind of cost savings ROI. You pay them whatever $250K or whatever it is, and they're solely focused on that. Every company is a health healthcare company, health benefits
Yes,
company.
it's the whole
Yeah.
Warren Buffett thing, right? He's a benefit,
Yeah.
auto companies are benefit companies.
Right. Yeah. So um, that's I love that.
Let me
Um,
give you one more insane piece here. This is the
okay.
ultimate in insanity. It's almost worth unionizing to get access to union healthcare plans because they can save you that much money.
Is that right? But are unions a middleman in and of themselves? Like, does that introduce
No, they are, but
complexity?
they've got it because they already have the scale, and they're what they do is aligned with what their members need. And
Okay,
so
fair.
because the CEOs have worked through multiple layers to get to the same point, unions can come in and just show them bam, 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 bam. Now, I'm not saying it'll work for everybody, but particularly small to medium sized businesses versus, direct buy from a buka, and using the buka for insurance. Yeah, big companies, it doesn't work. But for small to medium sized businesses or pushing their employees to the ACA,
Yeah, and that's interesting. I guess unions would have like a longer longevity of like a member, right?
well, it's not
Essentially,
even
too.
that. They already have these things in place. The Teamsters, they've been doing these things for decades.
Yeah,
They can't just offer it as a service because of Taft-Hartley. But if you unionize, and I know that's counterintuitive, but if you
yeah, that is
just
interesting.
do the math, particularly if you're a small business, how much more can you pay your people through collective bargaining versus how much do you save versus from their healthcare plans?
Hmm. Yeah,
You just never
interesting.
know.
Yeah, yeah, fascinating. Okay, let's see. Now, I think this is interesting. Unless you see any that interest you, Mark. What if like what are the most surprising or aggressive moves PBMs have made to deter you and or your company from disrupting them? So we've talked about transparency in general,
Yeah,
but
they lie. They lie. Oh my God. And even the head of one of them came out and said about me directly and name dropped me and said, "Oh, this is just a side hustle for him." You
yeah.
know, and
Well,
they'll
that was like
talk.
an op-ed, right? On like
Yeah,
Fortune or
yeah,
something.
yeah,
I remember seeing that. Yeah, I was like,
yeah.
this is crazy.
And they'll
Uh,
tell employers that, our drugs are short dated and all kinds of bullshit like that. And they'll tell the manufacturers, without saying it, without putting it in writing, don't work with them or we're going to reduce your prominence on our formulary.
Yeah. Okay. So, what they say and what they do isn't necessarily aligned publicly and privately. Sounds about right. Um, okay. This is an interesting one too from Matt Weeks. Some would say it would be a disaster to simply dismantle PBMs or restructure them, as transparent or regulated not-for-profit entities. What do you think like the fallout would be from doing that? Or like, is that a crazy idea?
No, I mean, dismantling which ones though? The pass through PBMs, it's not so much dismantling as it is disintermediating them, right?
Okay. Sure. Yeah, that's fair.
Making them so that you take each of their functions and companies buy each function independently. you know, um, which is how PBM started. They were just going to negotiate better pricing by aggregating volume, which is
Hmm.
great. Then they started, doing all the other stuff. And so
Hmm.
again, we partner with 25, 26, whatever pass through PBMs. I got no problem with those PBMs. That's why we partner with them. I think they're
Hmm.
great for employers. But it's the big three, four, five, six that have to hit their numbers, have to grow. You know, those are the issues. And it's not like the pass-throughs aren't making money. And I'm not saying they should be nonprofit. Capitalism for the win, you
Yeah.
know,
Yeah.
but align your interests. Nobody has a problem with you making money if your interests are aligned with the employer and their employees and lives. That's cool. Make money. Cost plus drugs. Well, we're not making money yet, but we should be making money in a not too distant future. You see our
That's great.
markup. You know what we're about. We're really transparent about it. Nobody complains that we're marking up 15%. Nobody.
Yeah. I mean, because it's just super
It's
transparent
fair.
model. They know it there.
Yeah.
Yeah. Okay. So we're pushing 30 minutes over, Mark. So I'm gonna take one last question for
Sure.
myself, and then let you wrap it up. But so I have just around cost plus drugs and kind of your mission here. Obviously, I want this to succeed and you to continue growing and like fucking up the healthcare industry, etc. that being said, like if it were to kind of like fall apart, but it results in like tangible change for the industry, would you still consider that like a success?
Yeah, for sure. Because I'm smart enough to recognize that if we're cost plus 15 and one of the big guys wants to screw with us, they can do cost plus one,
Sure.
or cost minus one or whatever, just to try to preempt us. But, I say this to our folks all the time. We're not in the medication business. We're not in the pharmacy business. We're not in the healthcare business. We're in the trust business.
Yeah.
And as long as we're transparent and people have every reason to trust us and we reward their trust with, doing what we need to do, then even if someone undercuts us, we're going to be able to retain a chunk of our business because they know that that change might just be an aberration. And the minute that one of the things I would get accused of when we first started all the time was, okay, these are just introductory prices. This is the free cocaine. And then you're just going to jack up the price. And
Yeah.
now we've been doing it for 3 years and people realize, no, we actually lower prices. We've lowered prices. Oh my God, like 90% of the weekdays over the past 18 months, we've announced a price decrease. And so people see that and that builds trust.
Yeah, I love seeing the updates on Twitter and all the other various social medias now.
And
You
by the
know,
way,
the new price of
I have a request. I have a request to everybody out there.
yeah,
So I'm not a big fan of Twitter. I talk pharmacy, I talk cost plus on there, but the hate levels because it's unmoderated are through the roof. I'm on this platform called Blue Sky. Please download the app and follow me at M Cuban. You tag me and ask me any follow-up questions, or DM me. I promise you I'll answer them, because I can answer them there without getting 50 people just talking ridiculous shit in the replies. They actually do moderation. And if you were on Twitter in 2015, when you could have a good conversation with somebody and engage with somebody, that's what it's like. And they have 31 million users. So yeah, I'm pitching them. I'm a tiny investor. I own like 0.5%, but it's really important. And I'd love to see more healthcare people on there. There's a bunch, but the more the merrier. And I'm happy to. I love to engage because that's part of what I miss on Twitter is just being able to have a good conversation about these things.
yeah, agreed. I'm also on X, I guess now, and it can be accessible. It's affected my mental health for sure. Full disclosure.
Well,
Um,
then
yeah,
I'm not saying leave X, right? But work on Blue Sky first.
yeah,
And then, if you need to send a message, then you're just broadcasting on X. You don't need to engage. You're not looking to
sure.
response and you don't care about your replies. So you can just turn off your replies.
Yeah, no, great point. And Mark, honestly, there's like 30 or 40 questions in the queue. Like, could I do a follow up with just like other questions here and like publish it in the newsletter later, or like something like that? Like, is that something you'd be
Sure,
open to?
sure. Or just put it
Okay.
on Blue Sky. I'll answer. Go to Blue Sky. I answer all these questions.
All right.
And Blake, are you on Blue Sky yet? Is Hospitalogy?
Not yet, but I will be. I'll ping you when that happens. So,
Yeah, do
um,
that. Go do that when we're done here. Tag Blake and post the question. I'll follow Blake and I'll just go through when I have time today or tomorrow just to crank out responses to all of these things. I like engaging with all this stuff. And I want people to disagree with me because that's how I learn. And
yeah.
the end game is important. That's why I did this podcast with Blake. Not just the fact that he pestered me every day, but the fact that yeah, that he's smart and you add value, Blake, and you make people smarter about this industry, and that's important.
Yeah, no. Thanks so much, Mark, for the kind words. And like totally agree. Like that's how you advance the discourse in healthcare. It's just, disagreeing and moving forward and being transparent. So thanks
Yep.
so much for this conversation today and for so much of your extra time and keep crushing it.
I'm trying.
I'm still in MFFL, so hoping for good
We'll
things
be
for the rest of the
okay.
year.
Anthony Davis is not bad, right? Anthony
Yeah.
Davis is good. We could actually have a better team this year for a playoff run, but long term, yeah, I'm not gonna go there.
All good. No, I know
All
your
right, man.
sentiments. So all right, take care, Mark. Thanks so much for
Appreciate
your
it,
time.
guys. Thank you.